your slides, but I'm here. Oh, we're live and recording. I'm here. I'd like to thank everybody for joining us today for what is the beginning of our spring MindCORE seminar series. We started a little late this year. We felt like people could use a bit of a break. We will be running weekly, it looks like, from now until April 23rd. So we look forward to our whole series of speakers this semester, and are particularly thankful for new professor at Annenberg, Andy Tan, who's kicking us off today. Before I turn over to Professor John McCoy, who is going to introduce Andy, I'd like to just say, talk a little bit about how this works. So you are welcome to post basic questions in the chat. You can post your appreciation, claps, whatever you would like pretty much in the chat, as long as it's polite. And if you have a question for our speaker at any point during the presentation, I encourage you to use the Ask a Question feature, which is a menu option at the bottom of the screen. And other attendees have an opportunity to upvote questions there. And so the questions that get upvoted are the ones that are most certainly asked. And I expect there will be a lot of questions on this fascinating talk. So now I'm going to turn it over to Professor John McCoy. Oops. Sorry, we had you muted still, John.
No worries. There is all the power. It's my great pleasure to introduce Professor Andy Tan, an associate professor at Annenberg, for our first seminar of the semester. I don't know, as you'll see, 1% of what Andy knows about the science of effective communication, but I do have the very unscientific intuition that people at least pay some attention to listicles. And so here goes. Item 1. In any competition for the number of degree letters after your name, my bet's on Andy. He has a medical degree from the National University of Singapore, an M.B.A. and M.P.H. from Hopkins, and a Ph.D. from our very own Penn. Item 2. Here at Penn, Andy runs the Health Communication Equity Lab, where his research is aimed at advancing communication science to achieve health equity for all. Item 3. Andy doesn't simply do research in the lab, he works extensively trying to put his research into action. So, for example, he's done lots of work with organizations that serve LGBT communities to develop health communication interventions really informed by basic science. Item 4. Outside of work, Andy's passions include orchids and scuba diving, which I think is just a fantastic combination. And finally, item 5. Recently, much of Andy's work has focused on how to help reduce health inequities with relation to things like tobacco and vaping. Again, not just in the lab, but really trying to change policy and practice. And it's that work that we're excited to hear about today. So Andy, with that, the floor is yours.
Thank you so much, John, for the introduction, and to Heather and Jessica for inviting me to this series to kick this off for this year. I'm really glad to be able to share some of the work that my lab has been working on over the past few years with everyone, and I'm looking forward to a interactive discussion afterwards, and also lots of questions and suggestions that you may have from your relative disciplines and experiences. So John mentioned earlier that my background has been in medicine, in public health, in health promotion, and more recently in public health communication. My work has primarily focused on tobacco-related health disparities over the past 5 to 6 years, and a little longer than that as well. The lens that I bring to the research that I'm conducting has to do with social justice and health equity. And you will see from the work that I'm presenting today that I draw from multiple disciplines and different methods, as well as theories and frameworks in approaching the questions, the research questions and the hypothesis that we are testing. So I see myself primarily as a pragmatist in terms of the philosophies of knowledge generation, and I'm looking forward to exchanging notes with everyone following this talk. So the work that I'm presenting today are funded by the National Cancer Institute, and I have no competing interests. I will share a very brief overview of the research framework that led me to the series of questions that I'm asking with regards to communication science and equity. I will share some findings from 2 recent research projects, and also outline a few next steps drawing from the current research that we're working on. So let's start with the overarching driving problem that my lab is trying to address through our communication science research. Given enormous progress in tobacco control in reducing the smoking prevalence all the way from 47% back in the 60s to under 14% in 2019, there are still enormous gaps in terms of understanding the burdens of tobacco use on human suffering. Certain populations are still disproportionately impacted by the use of tobacco, as well as exposure to environmental tobacco smoke. And we know that the benefits of various interventions, all the way from individual level behavior change interventions to policy to reduce the impacts of tobacco on population health, are disproportionately beneficial for various populations. So for instance, we know from a lot of descriptive information already that tobacco use continues to be much higher in prevalence in various racial and ethnic minorities, sexual and gender minorities, lower socioeconomic status populations, as well as populations in rural areas. So we need much better understanding of the underlying reasons for these disproportionate impacts of tobacco use in subgroups within the population, as well as research that will lead to effective tobacco control interventions to reduce and ultimately eliminate these disparities. So this is where I come in terms of our research, using communication science to try to address the underlying reasons for disproportionate burdens of tobacco on populations, and to use what we learn from communication science to ultimately develop effective and culturally responsive interventions. So what do we mean by tobacco-related health disparities? The NC Ph.D. defined tobacco-related health disparities as differences in the tobacco use patterns, the rates of prevention and treatment usage, the risk, incidence, morbidity, and mortality of tobacco-related illnesses, as well as the differences in the capacity and infrastructure that are available for tobacco use treatments, the access to these resources, as well as exposure to secondhand or environmental tobacco smoke. One of the underlying factors that I address through my research is the concept of communication inequalities and how it impacts tobacco use behaviors and its and related health outcomes. By communication inequalities, I'm using the definition from Dr. Viswanath's 2006 seminal paper that defines these inequalities as differences in terms of information exposure, information seeking behaviors, attention to health information, processing of the health information, which I know will be of importance and salience to many in the audience today, knowledge, comprehension of health information, and ultimately the capacity to take action based on these health information that people have access to. So one example of a communication inequality within this framework would be differences in the exposure to tobacco industry marketing across social groups. So in one analysis that I'm sharing here, we utilized a nationally representative survey data set of young adults in the US and found that there are significant inequalities in self-reported exposure to various forms of tobacco product advertising among young adult sexual, racial, and ethnic minorities, and specifically bisexual women who are between the ages of 18 to 24 reported higher levels of exposures to cigarettes, e-cigarettes, as well as cigar advertising compared with young adult women who are heterosexual. And we also observed that there were complex social patterning of tobacco advertising exposure by sex, sexual orientation, race, and ethnicity, such that young adult women who identified as both um, 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 uh, as both bisexual as well as African American or Hispanic were more likely to self-report that they were more exposed to various forms of tobacco advertising versus non-Hispanic white heterosexual women. So these are really important findings that lead us to more carefully examine how communication inequalities in the form of marketing exposure exist within the population. A second example of a communication inequality has to do with receiving health advice. So in this paper, colleagues and I have worked on analyzing data from the National Health Interviews Survey, and we found that between 2010 and 2015, there were persistent disparities in self-reports of receiving tobacco treatment counseling in the US context, even after the Affordable Care Act and meaningful use of electronic health records were implemented to promote the use of evidence-based tobacco use treatments. And by these disparities, we found that there were disparities based on race and ethnicity, as well as based on sex. A third example of a communication inequality has to do with the processing of health messages that are intended to reduce cigarette smoking or to promote smoking cessation. And in this paper, we conducted a study among a diverse sample from 3 Massachusetts communities and found that there were differences in whether participants perceived these Food and Drug Administration proposed cigarette warning labels as being effective based on their sexual orientation and race, as well as socioeconomic status. So the consequence or the implication of such a finding is that even if we are utilizing evidence-based public health messaging to try to promote smoking cessation, the potential benefits of such messaging may differ depending on the population's background. And we need to understand why that's the case and ways to ensure that our public health communication interventions are equitably impactful for populations that are disproportionately um, burdened by tobacco use. And the last example that I'd like to share has to do of communication inequality has to do with the knowledge and the use of treatments. And in this paper, colleagues and I examined data from enrollees of a large healthcare delivery system in California following the healthcare reform and found that Spanish-speaking non-daily smokers were much less likely to report being aware of evidence-based tobacco treatments and being aware that these treatments are available for free with no copay. And also they had the lowest rates of utilizing these tobacco treatments, including counseling as well as pharmacotherapy, compared with English-speaking patients. So there are marked and stark differences that we need to be aware of in terms of whether certain subgroups within the population are aware of these treatments and have access to these treatments and ultimately use them. So the 4 examples that I described briefly provide an illustration of how we can use this framework of communication inequalities to test and to test hypotheses in terms of the relationships between each of these forms of inequalities and the various tobacco-related health disparities and health outcomes. So these relationships are not occurring within a vacuum. They are embedded within a complex system. And these factors may involve individual level factors, interpersonal relationship, and other meso-level factors, and of course, community and societal factors. And the work that we are doing in our lab is trying to understand and also analyze the complex interactions between communication inequalities and these risk and protective factors at multiple levels in influencing tobacco-related health disparities. So I describe the program of the research at my lab along 3 different themes. The first theme is to describe the patterns of communication inequalities, including exposure, message processing, and the capacity to take action among vulnerable populations. The second theme is to address this question of whether these differences matter. How do communication inequalities, social and contextual factors interact to influence health disparities? And the third major theme of my research is to work on evidence-based and culturally responsive interventions. What can we do given the patterns of communication inequalities that we're observing and its impact on tobacco-related health disparities? And also to be mindful in our efforts to develop interventions that we want to be aware that there may be unintended consequences. And part of our research is also to examine and to mitigate any potential unintended effects of culturally responsive approaches. My work relies on a variety of research theories and frameworks, primarily media and message effects theories and frameworks, behavioral change frameworks, including the reason-action approach, the socio-ecological model, which I explained very briefly earlier, as well as critical theories such as minority stress and resilience frameworks, and in addition to that, implementation science, because we are really mindful of many evidence-based interventions that are left on the shelf because they are just finding a really hard time to be implemented in the real world. My research utilizes a variety of qualitative as well as quantitative methods, and I do my best along with my team to integrate these methods to triangulate and to make sure that the data that we're obtaining from participants provide a rich understanding and a more comprehensive understanding of the associations between communication inequalities and health disparities. So with that, I would like to start with sharing one of the projects that was recently completed in August 2020. This is a 2-year pilot study funded by the National Cancer Institute that we titled Project Spring, Smoking Protective and Risk Factors Among Transgender and Gender Non-Binary Adults. And I would like to acknowledge my study team comprising of investigators from the University of Massachusetts in Boston, the Fenway Institute, as well as at Penn. So as a brief background to this project, we are aware that transgender and gender expansive adults have twice the rate of cigarette smoking compared with their cisgender counterparts. Approximately 36% of transgender and gender expansive adults smoke cigarettes compared to 21% of heterosexual cisgender adults in the US. And this translates to approximately 350,000 individuals who are therefore at risk of developing smoking-related cancers and other illnesses. There's currently a critical gap in research to develop effective and TGE-affirming approaches that will reduce smoking rates among TGE adults and to promote smoking cessation. So the objective of Project Spring as a 2-year study was to examine TGE individuals' experiences of smoking, risk and protective factors in as close to real time as possible by using a digital photo voice approach. And I'm going to explain what that entails. So we developed a conceptual framework that was informed by the minority stress as well as resilience framework, and literature that has described through qualitative and quantitative research various factors that transgender or LGBTQ plus communities have identified to be either risk or protective factors associated with tobacco use. And we've organized that into multiple levels, ranging from the individual to relationships to community and societal levels. And using this framework, we developed a participatory action research approach and enrolled 47 individuals who identified as TGE from across the US and who are current cigarette smokers. We requested for individuals to first complete a baseline survey where they self-reported their tobacco use behaviors, as well as multiple measures informed by our conceptual framework. We then requested participants to upload photos as well as captions over a period of 3 weeks on a daily basis within private Facebook groups or Instagram chat groups. And following that 3-week period, we invited participants to complete a follow-up survey as well as either an in-person or an online video focus group discussion within their small groups to categorize and to help us label the risk and protective factors. And the point of this activity was to be able to understand how participants are categorizing these different factors in their own words. And finally, following a preliminary analysis of the photos and captions and the focus group transcripts, we invited a subset of the participants for a member check-in discussion to help us verify our team's interpretation of the results and also to discuss potential culturally responsive and affirming interventions that would be helpful from their perspective in reducing smoking within the TGE community. So I'm going to share some of the qualitative results that we have completed in terms of the analysis, and these results are currently under review. So briefly, the participants' characteristics are as follows. The mean age was 26 years. Half of the participants identified as non-binary. Half identified with multiple sexual orientations. The majority were non-Hispanic and white participants, although we do have some participation from African American as well as other racial and ethnic individuals. Half of the participants self-reported daily smoking, and about half reported non-daily smoking in the past 30 days. We grouped the qualitative results from the photos as well as the captions and participants' responses during the focus groups into 6 major themes of risk and protective factors, which I will illustrate with a few examples per theme shortly. And these include the experience of stress, gender affirmation, health consciousness, social influences, routine behaviors, and environmental cues. So these are just broad themes, but I will go through with examples of each one. In terms of experience of stress, several participants described how experiences of being discriminated, specifically due to their gender identity, as a source of minority stress that was related to their smoking. And day-to-day stressors were also described as potential factors that triggered increased smoking. And these included work stress, school-related stress, commuting, transportation, their financial situation, housing issues, as well as relationship conflicts. And here are 2 example quotes from captions of participants. Societal stresses such as homelessness, the state of the economy, the lack of access to affordable mental health care were also described as risk factors of their smoking behaviors. And here's one caption and a photo that was uploaded by a participant to illustrate this sentiment. Conversely, participants described using various strategies to reduce their stress and also in turn to avoid smoking by achieving relaxation or contentment, the use of humor or exercise to avoid picking up a cigarette to smoke. Gender affirmation refers to the instances where participants felt that smoking was a way to affirm their gender identity and to experience gender euphoria. So this was viewed as a risk factor, even though it made them feel affirmed in their gender identity. So this example photo and caption from a participant described how they felt that smoking is seen by some people as masculine and is affirming for them. Conversely, the feelings of self-esteem of one's physical appearance was also associated with not wanting to smoke. So this theme cuts both ways. It's double-edged, meaning that in some instances it was viewed as a smoking risk factor, but in other situations it was viewed by participants as being protective. The health consciousness theme refers to situations when participants felt that receiving gender-affirming related healthcare and advice from their healthcare provider in the context of receiving hormone replacement therapy, for instance, as motivating for them to not smoke. So in this quote, a participant stated that if a doctor told them that they had to stop using or administering estrogen for their treatment, and this will happen if they didn't stop smoking. That will motivate them to stop smoking. General physical health issues such as insomnia, pain, or mental health issues such as anxiety and mood were also identified as risk factors for smoking. But conversely, several participants listed having various respiratory symptoms, seeking mental health therapy, and practicing self-care as being protective against their smoking behaviors. So this is one photo and caption of a participant who indicated that having a sore throat made them not want to smoke. And we also grouped within health consciousness participants who described how they were concerned about the health of their family members around them if they smoked. And this motivated participants to avoid smoking. We got a lot of pet pictures with dogs, cats, and other animals among this group of participants who shared that they would avoid smoking near their pet to avoid harming their pet from exposure to secondhand smoke. By social influences, we refer to situations when participants were in the company of friends and peers and where smoking and other substance use were present as risk factors of their smoking behaviors. And conversely, positive family pressure and friends or peer norms to not smoke were associated with their avoiding smoking. So again, this is one of the themes that were presented as both a risk as well as a protective factor. Routine behaviors, including driving, drinking coffee, alcohol, and substance use, were viewed as risk factors of smoking. And this is one example where a participant was part of a party and there was a drinking game which made them want to smoke a cigarette. Conversely, having distractions was helpful to keep participants' minds and hands occupied and to avoid smoking. And this was one example of a participant who talked about cooking dinner, a healthy dinner specifically, and not wanting to smoke for a few good hours. Environmental cues included being outdoors, the weather, having access to cigarettes, and images related to smoking or being in a bar as risk factors of prompting participants to smoke. And conversely, there were environments or situations which discouraged them from smoking, including being in places where they were not permitted to smoke. So we found through our member check-in discussion that our interpretations of the data that we collected from them and the way that we grouped the data into the 6 core themes were largely supported. They also provided additional inputs, which were very helpful in our understanding of their experience of the study protocol. Several participants mentioned that that receiving peer support within their small groups, among other TGE persons that understood their experiences, was much appreciated. They really felt that that was a good experience. And having the closed groups and the closed chat groups within social media provided a safe space for them to connect and to share their experiences with other TGE individuals within the study. One thing that I should note that about this project was it was not intended to be an intervention to promote smoking cessation or to reduce participants smoking. And we actually had to turn away participants who were in the process of quitting smoking. But participants within our study described how the action of uploading a photo a day or captions related to their behavior actually increased their awareness or the mindfulness of their smoking behaviors and the underlying motivations to smoke, and made them seriously consider about reducing or quitting smoking. And finally, the procedures were generally viewed as acceptable and not overly burdensome for our participants. There were a few strengths and challenges and limitations that I will quickly summarize here. This study really demonstrated or illustrated an efficient way of collecting qualitative and quantitative data from a small sample of participants using a mixed methods convergent design. And we found that the comprehensive data from both the quant and the qual phases of the study really lent voice to the participants and gave us a much richer understanding of their close to real-time experiences with their smoking behaviors and risk and protective factors. And this project generated many new insights on participants' experiences of protective and risk factors in conjunction with their underlying intentions to quit. When we compared their survey data with their photos as well as captions and qualitative data from those sources. There were obviously multiple challenges and limitations in conducting this research among a vulnerable social group. We're aware that these individuals are self-selected into the study and their experiences may not necessarily generalize to the broader TGE population. There are issues related to retention and loss to follow-up, which meant that there were unequal sample sizes for the qual and quant phases of the data collection. And we're still in the process of addressing the challenge of integrating the rich visual and text data that we have from their photo voice phase of the study with the quantitative survey data that we have collected from these participants. So what are some next steps for this project? We are currently in the process of analyzing the data using a mixed method case study and case comparison approach to conduct a more detailed description of individual cases through the convergent use of both the qual and quant data from these individuals. So for instance, we're interested in analyzing whether the types of risk and protective factors contributed by individuals from their photos and captions differed between participants who reported in the baseline survey as having low versus high intentions to quit smoking. So this is one way that we can really hone in on potential differences in risk and protective factors across these different groups of participants to inform future interventions that are tailored to their experiences. We're currently in the process of developing an R34 application to NIDA to develop and to test a pilot intervention. And we're developing this intervention to be based on social media and to combine peer engagement with a self-guided acceptance commitment therapy approach. and to compare that with a control condition, which will be provided with smokefree.gov resources. So I know that we're running short of time, but I would like to share a second project that's ongoing. And this is a 5-year study which is funded by the National Cancer Institute, titled Project Resist, Increasing the Resistance to Tobacco Marketing among young adult sexual minority women using inoculation message approaches. So we are currently in the second year of a 5-year study, and we're well on our way to start collecting some serious data. So this is an overview of the study team, which is spread out across the country. We're really glad to be able to work with community-based organization leaders that are embedded within the LGBTQ plus community and serving the community for many years, with lots of experiences in policy, in advocacy, in healthcare delivery, as well as in tobacco control and health promotion. So as background for this project, we know that young adult cisgender sexual minority women have higher risks of smoking-related illnesses compared with heterosexual women. This is data from national surveys indicating that 33% of lesbian women, 44% of bisexual young adult women smoked, compared with 18% of heterosexual women. Young adult sexual minority women have up to 4.8 times higher odds of cigarette smoking compared with heterosexual women. And this disparity means that over 600,000 young adult sexual minority women are currently at risk of developing smoking-related cancers and illnesses later on in life. And I explained earlier about tobacco marketing disparities as a potential underlying risk factor to explain this disparity in tobacco use among sexual minorities. So multiple papers, including work from my team, has demonstrated higher rates of tobacco marketing exposures among various sexual minority groups. And this is the study that I described earlier, where we found that bisexual women reported higher levels of exposure to cigarette, e-cigarette, and cigar advertising compared with young adult heterosexual women in the US. We are using an inoculation approach and combining that with cultural tailoring for a few reasons. There are already existing or prior campaigns to counter tobacco marketing among young people and LGBTQ plus populations using both approaches independently. So one example is the Truth campaign in the 90s that targeted youth to increase their resistance to the influences of the tobacco industry. A more recent campaign from the Food and Drug Administration is the This Free Life campaign that utilizes culturally tailored or targeted messaging to prevent smoking initiation among LGBTQ plus youth. Another key component of this grant was to actively involve community stakeholders in community engaged research. And we believe through prior literature that engaging stakeholders in evidence generation is really critical to enhance future intervention adoption and implementation in the real world. So our goal here is to address the fact that the reach of evidence-based smoking cessation interventions is often inadequate because of barriers that limit the outreach, the implementation, and sustainability of these programs. So we wanted to make sure that we're engaging with community stakeholders from the get-go. We are actively involving LGBTQ plus individuals and organizations to design, plan these interventions that would ultimately enhance the reach of the program, the appeal, and its effectiveness. There are multiple research gaps that we are trying to address within this grant, and key among all, given my interest in communication science, is to determine the effects of combining inoculation and tailoring among young adult sexual minority women, What aspects of tailoring are preferred by this group of women, and what aspects are should be avoided? What is the optimal message type that we should utilize in addressing the needs of young adult sexual minority women with regards to their decisions about smoking or quitting smoking? Is there an optimal dose of this tailoring message? Is there a latency period before we observe the effects of inoculation? Should we expect an immediate change versus a delayed exposure effect? And would this intervention approach be generalizable in real-world settings, in a clinical setting, in the community setting, in a non-health setting? So we wanted to be able to answer these questions within this project. So we have 3 specific aims of the study. Key among all is to engage with with stakeholders that I mentioned, to optimize message construction, and to collect pilot data that will inform future intervention design and implementation. The second and the third aims are targeted at evaluating the effects of cultural tailoring and the inoculation message approach. This is a conceptual framework that is informed again by the socio-ecological model, the minority stress and resilience framework, and media and message effects theories, including inoculation and cultural tailoring. I won't go into great detail in terms of the steps involved in the study protocol, but we are currently in the second year of the study, and I would like to share very briefly the pilot data that we've collected so far to move us along in completing this project. And this is a very brief outline of the activities that we're involving our community advisors in. So let me start by sharing a summary of the message testing process that we've completed to date. We've obtained anti-smoking messages from existing literature and campaigns, and extracted central arguments from each of these campaigns and reviewed over 1,800 unique messages and over 800 central arguments that are anti-smoking. From these, we created draft messages that our external advisory board members provided really insightful written feedback, and revised and selected 34 messages for an argument strength rating study. And what this entails is an online survey where we invited young adult cisgender sexual minority women as well as transgender participants who are either smokers or non-smokers to rank the arguments based on perceived effectiveness, the likability of the messages, as well as whether they perceive that these messages will be suitable for an audience such as LGBTQ plus community members. We also collected open-ended comments for each argument. So to give you a sense of the types of arguments that we showed participants in this pre-test survey, there are anti-tobacco industry arguments, such as there's one thing that's certain about big tobacco, they know, they've always known, they just don't care, versus health messages that relate to the harmful health effects of smoking, such as you already know that smoking causes cancer. What you might not know is how many different kinds. So our pre-test survey is aimed at addressing 3 basic research questions. Do the perceived argument strength differ by participant sexual orientation, their gender identity, or their smoking status? And is there any interaction between smoking status and their sexual orientation in perceiving arguments to be weak versus strong? And how do participants perceive specific arguments based on their qualitative open-ended comments? We used a validated perceived argument strength scale that asked participants to rate each statement according to 6 different dimensions. And what we found was that there were no significant differences in overall perceived argument strength rating overall. by gender identity, sexual identity, and smoking status. And what that tells us is that we may not need to micro-tailor specific health messages based on individuals' gender identity, their sexual identity, or their smoking status in this population. We did not find significant interactions between smoking status and sexual orientation with regards to perceived argument strength. However, there were differences in argument strength rating across messages, and that leads us to be able to select messages that are rated to be to be stronger compared to messages that are rated as weaker in our next phase of the study. So to provide a few examples of open-ended comments that we received from participants, here's one. Here are two examples from participants who wrote about this particular argument that was one of the top-ranked arguments based on the perceived argument scale. And in contrast, here are qualitative comments from participants to an argument that was one of the bottom-ranked ones. So this example really gave the team some information about how overly targeting might be viewed as offensive or stereotypical for young adult women in this from the LGBTQ plus community, and that we really need to tread carefully when we are talking about culturally tailoring, that we don't overly culturally tailor to the extent that it leads to stereotyping or stigmatization of this population. So I'm close to the end now. The next steps for the project is to pre-test positively framed anti-smoking arguments and message concepts, and to create message concepts that include authentic images of young adult women who self-identify as LGBTQ+. And here are two examples from a recent photo shoot that we invited members from the community and told them that we are conducting this research with to create anti-smoking messaging for sexual minority women, and they've given us their permission to utilize their images for the purpose of this research. So we're in the process of developing additional messages using these images from the community, conducting cognitive testing interviews, and ultimately to utilize these stimuli for a large online survey experiment to test the relative effectiveness of using these versus a control condition where the cultural tailoring aspects are absent. So with that, I'd like to pause here and looking forward to any suggestions, questions, and a really interactive discussion. Thank you.
Thanks so much, Andy, for a really fascinating and informative talk about clearly a sort of super important issue. The first question is from Sharath Guntuku, who says, "Very cool insights from a combination of qualitative, quantitative data, and love the project names. I realize the challenges involved in collecting this data, privacy, technical time, and so on. Could you share your thoughts on how the insights from digital data and social media can be validated and scaled to broader populations for developing interventions?"
Got it. So if I get the question correctly, you're interested in how we can scale this beyond a smaller sample?
Yeah, I think the concept that the sort of this person points out there is sort of really difficult to get this data for a variety of reasons, and you've done a really nice job of getting it from these 40-odd people. But how do we sort of validate and scale this to broader populations?
Got it. I don't think there's one silver bullet to answer this thorny question in terms of implementing a project like this. So key to this, I believe, would be a close relationship with a community partner or community organization that has close ties and trusting relationships with the population that you're hoping to conduct such a project or research in. And this takes time from the researcher's perspective and also from the community partner's perspective. And one concrete example that I can think of to share with the audience is through this work, We've had multiple conversations with partners, both in academia as well as in the field, who are either embedded in community health centers, LGBTQ community centers that are not delivering health services, but delivering other forms of services, in order to develop our research questions and walk through the proposed study protocol to let us know what's feasible, what's achievable, what's completely crazy, you should not even attempt. And so that gives us a much better level of confidence in terms of whether the procedures that we are developing and are utilizing are acceptable and feasible and obviously sustainable. So we have utilized a variety of survey platforms and survey panels with participants who are self-identified as LGBTQ+ in order to help us validate the information that we're getting from the smaller pilot studies where we have more intimate information and richer information from our qualitative work. So you might need to consider being creative in terms of merging both qualitative and quantitative data to be able to scale the findings from a series of studies that involve fewer participants to a much larger cohort. And one example that I can share from our work, at least within the sexual and gender minority population, is there are existing cohorts based in at Stanford University's the Pride study, where they've been able to enroll over 18,000 participants by now, who are individuals who self-identify as LGBTQ+ for health research. So they are one of our partners in Project Resist, and we're really glad to have them on board.
Awesome, thank you. No, that was a great answer. I actually want to ask a question myself. So one of the things I was most struck by from your research was this demonstration that some of these groups sort of receive differential exposure to some of this tobacco advertising. And clearly one of the ways you can counter that is the sort of work your group is doing, sort of coming up with messages to sort of particularly try and inoculate this group. But I also have the intuition that it's just not okay for big tobacco to be sort of differentially serving ads to these sorts of groups. And so I wonder whether that intuition, that sort of moral intuition is widely shared. We sort of have evidence that folks don't like this kind of targeting. And then to what extent is there sort of public and policy sort of pushback to big tobacco saying, actually, this isn't okay. You shouldn't be targeting your ads in this way.
Absolutely. And we have this is such a good question, because that's exactly the rationale that we included partners from the California Tobacco Education and Advocacy Partnership. Bob Gordon is one of our advisory expert panelists within our community advisory board to address this question of pushing back against the industry or advocating for policymakers to consider tobacco control regulations against micro-targeting by the tobacco industry of various vulnerable groups or communities by race and ethnicity, by sexual and gender or minority status, rural versus urban. So we are really mindful of the fact that maybe a large part of the solution does not fall on a communication intervention. It will really rely on a multi-level systems level approach to ensure that we are preventing the harms from occurring in the first place, and then combining that with a counter marketing communication or messaging strategy to ultimately reduce some tobacco use disparities. And I really appreciated that comment, because it really highlights the need for a system level thinking as well as multi-level thinking in addressing this problem.
Great. Well, thanks so much, Andy. We're unfortunately out of time, but thank you again for, as I said, just an informative and important talk. I hope everybody will join us again on the 26th of February for a talk with Nicole Holiday, which we're also looking forward to. Heather, I don't know if you want to say anything to close us out. No. Well, thanks again, everybody.
That's all.
Thank you.
Thanks, everybody. Have a good weekend. Thank you both, John and Andy.
Thank you, John. Bye, Heather.
Thanks,
Bye. All right, have a good weekend.